and welcome. We're thrilled to see you all joining us here today, and we're excited to welcome back Dr. Greg Hickman for today's live webinar, Ultrasound-Guided Brachial Plexus Blocks, Techniques from the Expert. Some of you are joining us late into your evening and some very early in the morning. It's wonderful to see you joining us from all corners of the world. You're among 3,500 clinicians who registered for today's popular webinar, and you're in for a fabulous session. For over 30 years, Dr. Hickman has been performing brachial plexus blocks, and for the past 15 years, he's been perfecting his ultrasound-guided approach, which he tells us is safer and extends his block duration. Research does confirm that when brachial plexus blocks are performed under ultrasound guidance, they can improve the accuracy of the block and reduce the occurrence of related complications. The real-time guidance of ultrasound has the advantages of reducing the dosage of anesthesia without reducing the success rate and prolonging the duration of the block and the duration of analgesia. As medical and anesthesia director at the Andrews Institute Ambulatory Surgery Center in Florida, Dr. Hickman invited us into his office to capture real patient procedures on camera. So we'll be very lucky today to share these cases with you so that you can see both high definition imaging in action and also see his scanning techniques to help you hone your handheld ultrasound skills to perfect guided blocks and avoid complications. We'll hear from Dr. Hickman in just a moment, but first let me introduce you to your host. Shelley Gunther is an experienced sonographer and works as a clinical marketing manager at Clarius. She has over 25 years of experience as a clinical ultrasound expert with deep experience in both general ultrasound and echocardiography. At Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add wireless ultrasound to their practice. By delivering practical webinars like today and video tutorials for our Clarius classroom, which now features over 150 on-demand videos. Please join me in welcoming Shelley. Hi, Shelley.
Hi, Janess. Thank you so much. It's really great to be hosting another webinar covering a very popular topic, ultrasound-guided regional anesthesia, in particular, brachial plexus blocks. Ultrasound use for nerve blockade has really increased over the past decade and really is becoming the standard of care. I find it really interesting that after the last few Clarius webinars I've been a part of, how anesthesiologists continue to kind of customize their ultrasound guided techniques as they become more familiar with ultrasound and how and where it can be most useful and effective. Using ultrasound really is all about performing safer injections and providing the best care for our patients. Now, we always like to set the stage for our webinars by seeing what's new in the literature. And let me tell you, there's no shortage of information about ultrasound-guided regional anesthesia, which I think really speaks to how valuable a tool ultrasound has become, and as well, how common it is in practice and in residency programs. Now, I'd like to reference an article from ASRA that we talked about in a previous webinar, but I still think it speaks or shows the best data that we have so far regarding the increasing use of ultrasound for nerve localization. The big takeaways here are that so many benefits to using ultrasound, including hastening the onset of sensory and motor block, decreasing the performance time, overall fewer needle passes, the reduction in the occurrence of last, and decreased intensity of hemidiaphragmatic paresis. And all of these benefits result in better, safer outcome for anesthesiologists and their patients. In this recent peer review article from Minerva Medical asks, are we safe with reference to nerve damage during the procedures? And the authors stress the importance of using ultrasound to guide injections, specifically to avoid intraneural injections and to avoid anesthetic-related nerve injuries. The author mentions that the sole use of stimulation does not entirely prevent intraneural injections, and that over the past few decades, ultrasound really has become the gold standard in regional anesthesia. And this retrospective study from 2019 from the American Association for Hand Surgery looked at a large sample of outpatient hand surgeries to determine the effectiveness and the complication rate of brachial plexus block versus traditional general anesthesia. And in this large sample, only 0.6% had adverse events, which really further supports that the use of ultrasound to guide upper extremity blocks is safe and effective. And as you'll see in this presentation, Dr. Hickman is a fan of using both ultrasound and nerve stimulation for accurate nerve location. Now, just before introducing our guest, I'd like to do a little poll. I'm curious to know if you're using or have used or plan to use ultrasound. Is using ultrasound important to you as an anesthesiologist? Now, what do you see as the risks and limitations to blind injections? Are you struggling with accurate injections? Or are the injections where you think they should be, but they're not precise, like you're not getting an effective block? Is a procedure painful for your patient because you're hitting something you don't expect to be there? Do you find you're having to repeat the procedure? Are you hitting or injecting lung apex, a significant blood vessel, or you're injecting into a nerve and not around it? So let's wait a few more seconds for the results. And interesting, so inaccurate injections and hitting a nerve or pleura. So yeah, but kind of across the board. So I'm really hoping that this, the information imparted in this webinar will really increase your confidence moving forward for using ultrasound for guiding your injections. Now, this webinar is going to focus specifically on upper extremity blocks, and it's my pleasure to introduce our guest for today. We like to say that our presenter is a double black belt in ultrasound-guided regional anesthesia. Dr. Gregory Hickman is the Medical and Anesthesia Director at the Andrews Institute Ambulatory Surgery Center in the lovely Gulf Breeze, Florida. He is certified by the American Board of Anesthesiology and American Academy of Pain Management. Dr. Hickman also is co-founder of the popular ultrasound-guided regional anesthesia education website, blockjocks.com, which teaches doctors, nurses, and patients around the world. So without further ado, I will hand it over to you, Dr. Hickman.
Thanks, Shelley. Hey, it's quite an honor to be here. I appreciate the opportunity to talk about how we do things at the Andrews Institute. And I also want to just thank everyone for tuning in at basically all times of the day. I know it's really late in Europe, and as Jeanette said, it's really early in some other places. So I'm going to start off showing you what a sunrise looks like. I actually live on Pensacola Beach, was just across the bridge from Gulf Breeze where the Andrews Institute is. So we'll start with a sunrise and end with a sunset. And this is kind of what it looks like my first thing in the morning, some mornings for me. Then I head on over to work. Just so everybody knows, maybe you don't know much about me, I'm a private practice doctor. I've been doing private practice for about 30 years. I did do 1 year of in an academic setting when I trained at the University of Alabama, Birmingham, Alabama, of course. And I stayed there on staff and started the first acute pain service. And then in 1992, I went to a private hospital in Birmingham called Health South Medical Center and started working with a group of guys called Alabama Sports Medicine Orthopedic Center. And in that group was a guy named Dr. Jim Andrews. And Dr. Andrews is probably the most famous orthopedic sports medicine doctor in the world, and probably will always be that, to hold that title. And so in 2007, he was recruited down to Florida, to the Gulf Coast, and we built what we call the Andrews Institute. It's an 8 OR surgery center. It's got a big physical therapy department, surgeon's offices on the second floor, X-ray, 3 Tesla MRI. It's got a outpatient training facility where college athletes come and train for the NFL Combine. I have a big educational center. This is all next door in a separate building. And so it's kind of the everything you need for an active sports medicine center. And I started using ultrasound in 2006, and I've done a lot of talks and educational programs on ultrasound-guided regional anesthesia. And as you stated, we started blockjocks.com, and I was a co-founder of that a few years back. So we're going to talk about 3 blocks today. We're talking about upper extremity surgery, So we're going to talk about supraclavicular blocks, infraclavicular blocks, and axillary blocks. These three blocks can be basically used interchangeably for surgeries below the shoulder. From the elbow down, you can use any one of these blocks, and sometimes you might want to use one over the other. You might use one of these 95% of the time. Interscalene blocks are not really good for upper extremity surgery below the shoulder. It's common to miss the ulnar nerve, and so therefore you'll have problems with elbow surgery or hand surgery that gets down on the ulnar side. So don't recommend it when we got these three other blocks that all work really, really well. So what do we use in these blocks? We're going to use bupivacaine or ropivacaine if you want a prolonged, long-acting block. You really use the bupivacaine 0.25% is plenty strong enough and lasts long enough for most cases. You really don't need to use 0.5, but you can if you want to try to extend the duration a little. If you want a short block, you can use lidocaine 2%. We don't really do that here, very, very rarely, because we're usually trying to get a prolonged duration from our procedures. We're going to use about 20 to 30 cc's volume, usually 30 cc's in all of our blocks. You can add dexamethasone to bupi or ropi to try to prolong the duration. 2 to 4 milligrams is what we use. Epinephrine can be used to add to bupivacaine if you want to try to increase the duration. Supposedly, if you use Decadron and Epi, you can get up to upwards of 30 hours of duration on your sensory block. We don't really add Epi. We just get enough duration with just the dexamethasone. And as Shelley said, I do believe a nerve stimulator is important. I think it's very helpful. You can use it for several things to find your nerve, although that's probably not that big of a deal. It's helpful to find nerves that you don't see well that are in your path on the way to certain other nerves that you're trying to find. You can also turn it down and make sure that you're not intraneural with your injection. So nerve stimulator is only helpful. I remember when ultrasound came out, and all the ultrasound reps were saying, "Oh, you're gonna quit needing nerve stimulator. You're not gonna need that anymore." So a lot of people did that. I think the trend now is going back to doing dual guidance with a nerve stimulator and ultrasound. And some people use triple guidance when you throw on pressure monitoring there. So let's talk about the supraclavicular block. It's what we call the spinal of the arm. It's our go-to here at Andrews. It gives complete analgesia, actually from the shoulder all the way down to the hand. So you can actually do shoulder surgeries, especially for post-op analgesia with the supraclavicular block, but we really use it for our hand and elbow cases. And it's our popular block here at the Institute. So we're talking, we're going to be blocked. Here's our schematic of the brachial plexus. And we're looking at the level of divisions. We're really going to be right here on top of the rib. And so we're kind of right where the divisions, where the trunks turn into the divisions. So we'll look like this initially. And then once we start injecting, we'll start seeing the trunks separate. So it's kind of a fun block to do, to watch all that happen. So looking at the anatomy, we got the first rib. We got the subclavian artery coming over the first rib, subclavian artery, subclavian vein, and then the blood plexus is just posterior to the artery, coming right over the first rib, and then they're going to go right under the clavicle. The clavicle's kind of cut out right here and here, so you can see that. But the first rib is going to, in the artery, are going to be key to doing this procedure. So what we're going to try to find is the artery and the rib, and then the nerve setting just on top of the rib, just posterior to the artery. And they'll actually look like a group of grapes a lot of time. That's a common term for a supraclavicular block, is find a group of grapes just posterior lateral to the subclavian artery, and that's our go-to. That's where we're going to try to go. So how are we going to do this block? We'll walk through it here. First thing we're going to do, we do 95% of our blocks in the pre-op area. So we'll have them on a stretcher, and we'll raise the back of the stretcher about 30 degrees. Just makes it comfortable for us and the patient. Have the head turned to the opposite side, and then the arm can be just neutral down to the patient's side. And then we have plenty of room to put our needle. So we're going to put the probe here. We're going to bring our needle in posteriorly back here. So the first two landmarks we're going to find is the clavicle and the sternocleidomastoid. You turn the head to the opposite side to identify the sternocleidomastoid. And we're going to put our probe here initially just posterior to the rib, and we're going to shoot straight down towards the heart, just straight down. And then here we can see the clavicle. I'm just posterior to the clavicle down in this this area in here. And then we're going to take the lateral edge of the probe and rotate it posteriorly to find the rib. So here we are, clavicle. You can see this probe's rotated a little bit further away from the clavicle, so we get a nice view of the rib that we're looking for. And then we're angling the beam just under the clavicle, straight down towards the waistline, to the heart. Okay, so first thing we want to do is identify the artery in the rib. And what that does, it shows you areas you don't want to take the needle. You don't want to go into the red artery or down into here to below the pleura, into the nice little lung area. But we want to go right in this area where our grapes were and put local around our friendly little smiley faces with our nerves. And you can see this is kind of where we're coming from at this angle. This probe again is rotated away from the rib, and this is a typical kind of angle. We're going to come back really kind of posterior to anterior with our approach under the probe. And our first injection, we're going to shoot for this corner pocket down here between the artery and the rib. And when we inject down here, that's going to just raise the whole plexus up like this. It's going to, this local down here is going to push the plexus up. Then we'll go back and get between the trunks. But the corner pocket's your first shot when doing a supraclavicular block. Here's the needle coming in. You see the rib here. The rib is easily identified because it's going to be dark below bone. Below the rib is going to be really dark. The pleura is over here. It'll be a little more gray down below it, and pleura will be nice, white, and shiny. The rib will be a nice white bone, and it doesn't allow ultrasound to penetrate, so it's going to be real dark below the first rib. So here we come with our needle. Here's our rib. See a little bit of pleura there. Here's our subclavian artery. Here's our group of grapes all hanging out here. We're pulling this right into that corner pocket. We're going to put 5 to 10 cc's right in that corner pocket and lift this plexus up away from the rib. All right.
Dr. Hickman, you can see your needle really well because of the angle that you're going in, right?
Yeah, we like as flat an angle as we can. We like to be as parallel to the probe as we can be. So we've already injected it. Now we're going to inject up under the upper trunk. So we went to the corner pocket. Here's a second video of the artery. Now we're up right under that upper trunk there. And I think that's really all we see in that video. Going to move on. Well, there we see it.
Great.
And then our third video here, we're going to come in and inject on top of the upper trunk. So it's real easy to see these trunks separate. And upper trunk, middle trunk, and lower trunk.
And the analgesia really enhances the appearance of those nerves, right?
Yes, when you get your local around there, you see the nerves much better. The local adds contrast to the nerves. Now we're going to watch it from with the Clarius, the whole thing. So you can see we got the head to the right with their little caps kind of in the way, but we got the probe just behind the clavicle. You see the rib extremely well here. You see the subclavian artery, and then you see pleura back over here. There's pleura nicely, because you can see it's gray underneath the pleura as opposed to being really dark beneath the bone. There we go. Pull the hat out of our way. And then you can see how I can just lay the iPad right here on the patient's chest. I got the probe rotated back around away from the clavicle, the lateral side away from the clavicle, which gives us our best view of the rib. So if you turn the gain up a little bit, it's really easy to touch the iPad, turn the gain up. So now you can see pleura really well here on both sides, and then rib right there. Now this one's going to be kind of shallow, and we're going to have to come flat in there to get into that corner pocket. You can see the angle we're coming at. This one is so shallow, you don't have to go too far away from the probe to be able to see the needle coming flat across the screen. And we'll bring it in kind of like this. Sometimes you have to get your entry point much farther away from the probe to be able to get the flat needle to see it really well. So here's our needle tip. Now we don't want to go down in that direction. We're going to stay up here and skim right over that first rib.
And are you actually touching the rib there?
Yeah, you'll go in, you can feel the rib, you let the needle hit the rib, because if you see your needle and you see your rib, you're completely protected. You're going to hit that rib. You're not going to go deep and get into the pleural. That's totally a safety precaution there, and it makes it completely safe. And they may feel it hit the rib, but it's not, they're not going to jump up or anything. They may go, ow, but you can slide, and you slide right across that rib. And if you touch it at any time, that's fine. So I think I'm doing, I'm injecting a little bit here just to kind of open up my space to help me get down into that corner pocket a little bit easier. So you can see this is all local that I just injected. I think I'm going to come back in there and try to get further over here to the corner pocket.
And it just lifts that bundle right up.
Exactly. Yeah, it picks it right up. You get in the lower trunk, the ulnar nerve really well down here with this injection. Some people just do the whole injection, 30 cc's down here in the corner pocket, and seem to have success. We see the needle so well, we see the plexus so well, we like to manipulate the needle and go up and get the upper trunk too. It's real easy to get under the upper trunk. So now I'm coming in. So we've got this down here in the corner pocket, and I'm going to try to come in and find the upper trunk. She's so compact. This patient's nerves are so compact. There's really not a lot of room to try to find the upper trunk. So in that case, sometimes what I'll do is scan up the neck, and you'll see the trunk separating better that way. I think I'm trying to get under it right here, under the upper trunk. Let's see. We can inject here and see if it can in the right place or not. Sometimes I'll just stop on the side here and inject and see if there's an opening that starts skimming away. There it goes, just popped open. So now I can come right on in through there and push the upper trunk up a little higher and the middle trunk down a little here. And we'll inject a little bit more. You see it a little bit better. And there's where I scanned up the neck a little bit, and you can see the trunks separated.
Wow, that's so impressive how well you can see them.
Now, yeah, now you see them. Really got good local spread all around, in through here, underneath, on the top.
You said a total of 30 cc's.
30
in total, right?
Yeah. Sometimes you're just trying to look for a place to put the last 5 cc's because you kind of got the local everywhere. Now I'm on top of the upper trunk.
Right.
Just shooting right over the top, pushing everything back down. Push it up, push it down. All around, I guess. So now you can see the artery, see the rib, you see the plexus. As you said earlier, you see the plexus better after the injection because you have a contrast between the dark local and the hypoechoic nerves. Actually, they're and you see a nice bundle there. See the grapes. So here I went back down to the corner pocket again. I'm finishing up down here in this area, just lifting up that lower trunk again, and we're coming out, and we're finished with that supraclavicular block.
Great.
So now we move on to the infraclavicular block. So this is like between the axillary and the supraclavicular blocks. We're at the level of the cords. So at this level, we have the lateral cord, the medial cord, and the posterior cord. You're going to see what all that looks like. This gives you a nice block. It's very predictable, nice onset, like fast onset, like the supraclavicular block. So it's a good block too. It's just a little more technically difficult, but it works just as well. And after a little practice, it becomes just as easy. The cords sit down here. Here's our drawing again. Here's our lateral cord, medial cord, or posterior cord, and medial cords. And the issue now is we got the subclavian artery going right through the middle of that. So they're surrounding the artery and the medial cord is between the artery and the vein. So you start here with supraclavicular with 5 and 6. So you're only getting this upper trunk really. And then you got the supraclavicular where they're getting everything from C5 to T1. And again, we're getting everything from C5 to T1 when we're doing this block. So it's a solid block for the whole arm and hand. Now, our supraclavicular was right here. Our infraclavicular block is right in this area. We used to do these blind without ultrasound. And what I would do is come 2 centimeters medial and 2 centimeters inferior from the cord process here. And it was a lot of fun. I used to love to do this block because you just take the needle and go straight from anterior to posterior. And people would walk by and they thought, oh my gosh, he's sticking that in the lung, which you're really not. You do the chest wall here and you're really outside the lung. And we can look at this. As you're coming through, you're going straight from anterior to posterior. You go through the pec major, through the pec minor, get little muscle twitches, and then you go through that and you get down here and you get one of the cords and you start getting a hand or biceps twitch. And that's where you want to block. But you can see there's the artery, there's the vein. It's very vascular, but you're really outside the chest wall. So here's the lung, here are the ribs. So you shouldn't be anywhere near the lung with this approach coming in out here. So this is good for catheter technique. This is our preferred block when we're putting in a continuous catheter for hand or arm surgery. This is our preferred block at Andrews. It stays in location better. We know exactly where to put it. So we'll get all 3 cords and we'll keep a complete block. And like I said, there's a potential for vascular complications. So let's walk through doing this block. Again, we're going to have the head of the bed up about 30 degrees if you're on a stretcher, and you can get that done easily. If they're flat, that's fine. That just makes it a little easier for you to do it with the head up 30 degrees. Turn the head to the opposite side. Then we're going to put our transducer just below the clavicle and just medial to the cord process. So we're really just putting it kind of in the delta pectoral groove. And we're going from superior to inferior, we're going from a super medial position to an inferior lateral position. So we're angled a little bit out laterally as we're going down the chest wall. So when we get there, you're going to see the pec major, you're going to see the pec minor, you're going to see the artery, the axillary artery, and then the lateral cords be out laterally. We're coming in this way. So it's going to be out here. The posterior cord's going to be usually about right here. And our medial cord is between the artery and the vein. The vein's sitting over there. You don't see it well on that picture. So what are the nerves the distal nerves we're talking about? So the lateral cord, which is the first cord you're going to come to, and you're going to get stimulation. This one's great to use a stimulator with because you can see all the different cords. The first thing you'll get from the lateral cord is a musculocutaneous twitch, which is a biceps twitch. And you'll see the arm popping up like that. And it also has the median nerve in the lateral cord. The posterior cord is just the radial nerve. And then we get to the medial cord, it has branches of the median again and ulnar nerves. So the lateral medial cords have the median nerve distribution, and then the ulnars, the median, and musculocutaneous in the lateral. So this is coming in. The first thing we're going to get is the lateral cord. Here's a musculocutaneous twitch, nice biceps twitch. And after you go past, you go down under the artery, and then you get the tip of the needle over here to about 7 o'clock. You're going to see this nice median nerve twitch. That's the median and ulnar nerves. You can see the needle coming right over here, the median cord over there, medial cord over there. So there are 3 different approaches to the infraclavicular block. This was the initial approach we used about 15 years ago, where we put the probe here in the delta pectoral groove. We came anterior to the clavicle, and that really made a steep approach with your needle. Really hard to see the needle with this approach. So these 3 guys, Jeff Gonzalez, Jim Bononis, and Dave I. Young, were fellows at Duke at the time, and they came up with the Houdini effect. And basically what that means is you abduct the shoulder. So if you put your finger on your clavicle down at your side and you abduct your shoulder you'll feel the clavicle move back posteriorly, giving us a little more room to stick the needle in. So it's not so steep, it's a little flatter. So it's going to look a little more like this. And you're still in front of the clavicle, you're still anterior to the clavicle, but you're not coming straight down like the old technique. So just abducting the arm can be really helpful from that standpoint. So here's an injection from the initial approach with the needle super steep. You can see the local spreading down here below the artery. You really don't see the needle well. That takes a lot of practice to get good at doing that one because it's really hard. But it's going to get a nice block because we're local spreading completely around the artery there to all three cords. Now here's an injection where here's the lateral cord here, and our needle's coming in a little flatter, so you can see the needle better coming this right there, all the way up through here. So you see the needle better. This is the Houdini approach. We got the needle down under the artery now. We're going to inject right there, and again, local spread. But you can manipulate this a little better. You can get over to the medial cord. You can come back under the lateral cord and do injections there. So the third approach, which is now what we're doing at the Andrews Institute, is the retroclavicular approach. At Duke, they call it the Raptor approach. Grant presented this about 4 years ago, 3 or 4 years ago at ASRA, and other people have been doing it. We've been doing it a lot since then. So this is a great block. No special patient positioning needed. The arm doesn't have to be moved. It can stay down. You see the needle really well with this one. What you're going to do is we're going to put the probe the same place, and you leave the arm down at their side, but you start the needle posterior to the clavicle. So the needle's not going to be seen until it comes out under the clavicle. So the needle you get a much better needle image coming with this approach. And it's a good needle control to manipulate to all three cords. And again, I said you don't have to manipulate the arm. So here we are. You got the probe up here, but you coming up where you getting a little bit of the clavicle there, and this needle's way posterior, going deep to the clavicle. So it's going to be coming straight parallel with the face of the probe. We're going to see the needle much, much better with this positioning. Here we go from another angle. You can see the probe in the delta pectoral groove. You're kind of up on the clavicle, so you can see the clavicle, and then the needle coming deep underneath the clavicle. So what it's going to do, here's our cords. Here's our cords. Here's our lateral cord, posterior cord, medial cord, axillary artery, and vein here. But you got the clavicle. So the needle's going to come under that, and we're not going to see it till it pops out into here. But it's nice because it's coming usually straight right at the lateral cord or just below the lateral cord. So we come in, inject here, 5 or 10 cc's there, come down to about 7 o'clock, do 5 or 10 cc's to get that posterior cord, and then come on over medially under the artery and get the medial cord. This picture, you see the needle coming in, and you can see how well you can see the needle and all the cords.
Perfect angle for ultrasound.
Yeah, perfect angle for ultrasound. So you see we're injecting right here, pushing the lateral cord up, pushing the posterior cord down right there. You don't see it as well. And then we just come on under, and boom, we'll get the medial cord. So like I said, this is a nice block for catheters because we'll put the needle tip about right there, thread our catheter out to here, and then just lay it under here so that when we have an infusion or bolus doses, it'll spread all along this direction here, and you'll get a nice good spread to get a nice continuous infusion block with it. So when we're doing catheters, we use bupivacaine 0.125%. And the way we dose those, we don't do a continuous infusion anymore. We used to. Now we like electronic pumps. And so we'll set it at an 8 cc bolus every 4 hours. So, if you got that catheter laid right under the artery and shoot a bolus, 8 cc bolus is going to spread out and get all three cords every 4 hours. Now, the patients have a demand dose every 2 hours if they want to use it, but they don't use it very much. It's rare. So that's worked out really well for us. What are our side effects with infraclavicular blocks? Now we're further away from the phrenic nerve, the Horner's, I must have skipped this slide on supraclavicular. Supraclavicular, you can get a phrenic, you can get a Horner's, you can get a recurrent laryngeal and get hoarseness. Pneumothorax with both of these should be extremely rare. Supraclavicular, if you see the rib and the needle, you shouldn't get a pneumothorax. This one, we should be way outside the chest wall. If you start seeing ribs, if you look medially and see ribs, you need to turn your angle of your probe back out more lateral. And of course, last is always a risk with any block. That's why there's always careful injections, and aspirations are always important with any block. Of course, the ultrasound visualization is nice. If you see the spread of the local, you know it's not intravascular. All right, so there you go. There's the rib. So I'm aiming too medially. So what I need to do is straighten the probe up and have it come out a little bit more laterally. I'm showing you where we're going to go behind the clavicle with my finger. Bring the probe out looking more anterior posterior so we get a nice view of the artery. Here's our clavicle, pec major, pec minor, right there, major minor, clavicle. So we're going to bring our needle in underneath the clavicle. So I'm going to change the orientation. That was, I want to change it more to like what we're seeing on the screen is what we're seeing on the patient. So we're going to bring the needle in from left to right, just in that direction. And so I'm going to have the needle coming from left to right on my ultrasound probe to make a little bit more sense that way. So there's pec major, pec minor, subclavian artery, lateral cords up here, medial cords in here between the artery and the vein. Seems to be collapsing the vein a little bit. And I can't see the clavicle because you can see I'm down below, I'm inferior to the clavicle, so you don't see it. I know my needle is going to come in here and I'm not going to see it on the clavicle, so I don't usually put it up on the clavicle. I just did it earlier for a demonstration. So again, nice musculature here. With pec major, pec minor. Now here comes our local injection. We're going to put that under the clavicle, deep to the clavicle. So we're going to come in this way with our needle. Well, speed along here.
It looks to me like you're so far away going under the clavicle like that, but I guess you're not. Like it's just odd to me that you're going underneath the bone. But
yeah, you're pretty far away from the probe. I agree.
Yeah.
But I do a lot of blocks that way. Minor scalenes are even further than that.
Huh.
And so that's not unusual for me to go pretty far away from the probe to get that needle lined up with the probe so that it's parallel to the face of the probe where you can see it. As you can tell, you can just see it so much better.
Yeah.
Here comes our needle in here, right under the lateral cord. Should be good. Yeah, you see, can't really see it twitching well, but a little twitch in there. We should do some injecting right here. There we go. Pushing up the lateral cord, pushing the posterior cord down. You can come right on over the artery and under the lateral cord, or over the lateral cord to get to the medial cord if you want to, over the top if it's easier. Or we'll come back. I usually come under the artery and inject down here to get the posterior cord, and then come on over to about 5 o'clock and inject to get the medial cord.
And I guess if you're that far from the lung, you're not concerned with this one that you're going. If you go in a little bit steeper, that you're not gonna run into lung.
Right, because you should be completely lateral to the lung, so you can see the chest wall should be in there. And we're going way outside. We're really out here closer to the shoulder, the axilla, really.
And so you're going to inject underneath the artery now to get the posterior cord, right?
Well, we got the posterior cord here.
Okay, right.
Come on under the artery to get the medial cord over here between the artery and the vein. You can see it right there.
There you go.
Yeah. Come on in. And
so you just kind of want the analgesia to kind of surround that artery, and then that ensures that you've
correct.
that you've hit all of the cords.
You can literally come put the tip of the needle at 6 o'clock, inject 30 cc's, and most times it's just going to surround the artery and collect all 3 cords. The nice part about this, you see the needle so well, you can just get the tip next to each cord and make sure you dose it up really well.
Yeah.
Yeah. It's kind of like an axillary block. Same thing. You just want to surround the artery because you know the nerves are around the artery.
Right, right.
So here we are, right there. Nice needle view. Come on, inject, would you? They're going to show it. Oh yeah, see, we got the needle way over here.
Yeah.
There we go. There's the local spreading around.
Right. And that's the vein that's medial there. Yeah.
Right. Yeah, right over here.
Excellent.
So
great.
Oh, that's how you do the infraclavicular block. And then you can inject some on the way out if you like.
Yeah, you have leftovers.
Pec major, pec minor, artery, lateral cord, posterior cord. Medial cord's kind of hard to see, but it's in there.
Yeah.
In that area. So we're talking about upper extremity surgery, and you can see why baseball pitchers seem to have problems with elbows. And we do a lot of elbow surgery down here, Tommy Johns and all kinds of stuff like that. But that's incredible torque on that baseball pit. That's a long time ago. That's about 20, 25 years ago, but they still throw like that. So moving on down to the axillary block, usually multiple injections again, because we got 4 distal nerves, highly vascular again. There's lots of small veins, so you got to be a little bit careful here. The block is technically really easy because it's very superficial. And so it's kind of a go-to block for some guys. So we're down here at the distal end of the brachial plexus. We're talking about the median nerve, musculocutaneous nerve, the radial nerve, and the ulnar nerve. So we're down at the end of the plexus to the individual nerves at this point. So why do axillary blocks? Like I said, it's really easy. Some people use it as their go-to block. They don't do supras or infras that much. They just do these. Not a problem with that. Like I said, we like the supraclavicular is our primary block, but sometimes when we see a guy that looks like this here, we know a supraclavicular or an infraclavicular is really going to be tough. Whereas you start looking at his axillary area and it's really easy. These nerves are really superficial. So no matter how big he is, the artery and nerves are going to be right out here in the axilla, and they're going to be really superficial and easy to get to. Now we're looking at the ulnar nerve, the median nerve, the radial nerve, the artery, vein, and then the musculocutaneous sits out here in the coracobrachialis muscle. So we're going to come in plane. Again, I'm starting my needle kind of far away on this one from the probe. Sometimes it's closer depending on how big the patient is. But again, we want to come straight down and run the needle parallel to the face of our probe to get our best view. So in this one, we got the musculocutaneous is right here. It's kind of hard to see. If you don't see it real well, sometimes it's just a long, thin thing like this. Sometimes it's a little triangle. But if you don't see it well, you scan up into the axilla and you see this nerve come right on up into either the median or the radial nerve. And so just a matter of scanning back and forth a little bit. Here's like our median and radial nerve are kind of combined, and our ulnar nerve is back here posterior to the artery in this area. So here we are. I actually have pushed the median nerve down, and so we're going to inject on top of that. This is real unusual. Usually the median nerve is sitting up here at 1 o'clock, but with this local, we're pushing it way down with that block. And then I push it down, then I'm going to come back and just surround it. I use about 5 cc's on each one of these nerves. And that's the first injection on the median nerve. So now I'm over the axillary artery, trying to inject around the ulnar nerve. You don't see it real well right now, but after we inject local around it, you'll see the ulnar nerve pop out really well right there. That's where your nerve stimulator can be really helpful to let you know where those nerves are. And then this is a muscular. Like I said, sometimes it can look like a little triangle. Artery's back way over here. This is in the middle of the musculocutaneous or the coracobrachialis muscle on the way into the axilla. And then we have a nice little musculocutaneous nerve right there.
Yeah, easy to see on that one, but not always.
Right. Side effects really shouldn't, we're not going to worry about phrenic nerve or recurrent laryngeal nerve here. But pneumothorax is still a possibility. You'd have to be really wild and crazy with your needle, but we know that pneumothorax is a known complication of shoulder arthroscopy. So if you can do it with a shoulder arthroscopy, we can do it with an axillary block. So just be careful, stay out in the axilla, and it should be fine. And of course, LAS is always, like I said, always a risk. We should always be aware of and be careful with. Here's our axillary block with our Clarius machine. Again, just talk about the Clarius real quick. This new version, version 3, is just fantastic. I've had all 3 of the Clariuses that they've come out, and the images now are just much better than they were. You can see how easy it was. I'm changing the depth of the screen, just touching the iPad. I can change the depth. I want it kind of shallow for this one, and it's something that's real easy to do.
And the wireless aspect of it must be much more convenient as well.
Oh, absolutely. It's so portable. I mean, ultrasounds need to be portable, and they're kind of portable, but when you're rolling around a big cart, this is so much easier to carry around either your iPhone, which is there in my pocket, or your iPad, which is sitting right here on the patient, and the Pro. It's much easier to carry those 2 things around. I mean, recently I couldn't get the iPad working. I just turned on my phone and used it. The images are really good on your phone. So we're going to come in here, trying to get our musculocutaneous nerve. It's sitting right in here, I think. Yeah, there it is. And we're going to inject some local. I usually do that first before I go into the artery.
Kind of on the way in.
Yeah, exactly. Like you see, we're right in the middle of this muscle, coracobrachialis, and it's right in the middle. When we used to do this blind, we literally just went down to the bone and then just injected on the way out, try to get it. It was really just a lucky shot kind of block. But now we can really get it specifically. We see it extremely well there.
Ultrasound just must be such a game changer for you guys. Like
Totally.
Yeah.
Like I worked 15 years without ultrasound, and you do a lot, you get pretty good. But as soon as I did ultrasound the first time, I said, oh, this is going to change. This is going to change the way we do everything. I didn't realize the true impact of how much it was going to change and how many more people will get into regional anesthesia, because so many people can feel more comfortable with this than trying to do those blind techniques.
Absolutely.
It's really improved regional analgesia and anesthesia. So here I am under the artery here, trying to get down and find the radial nerve. I'm using a nerve stimulator. It's kind of hard to see the radial sometimes. Sometimes it's back here, sometimes it's under here. Sometimes you don't see it well, so I'll just put some local underneath, and then we'll go up and go over the top of the artery and get the median nerve. But like you said earlier, I think ultrasound is definitely the standard of care in the US at this point. 10 years ago, it certainly wasn't, but I think it is now if you're doing regional anesthesia. So I'm trying to get a twitch here. Make sure I'm on the median nerve. And that should be it right up there.
Right.
So we should be injecting. There we go. There we are. That's the nerve. There's the artery you should inject right there. Yeah, there we go.
Nice.
It'll actually push your artery down too, you can see.
Yeah.
Things are really movable, viable, whatever in this thing. There's our axillary block.
Axillary block.
And so for anyone that's interested, just a heads up, we have a 2-day preceptorship at the Andrews Institute where you can come down and hang out with myself and Dr. Thomas and watch how our program runs, watch how our blocks are done, watch how we set up our pumps, how we do our blocks, how our nurses work through the day, and how we get 20 to 30 blocks done in a day. And you can get the CME. I think it costs about $2,000, but we are right here on the beach too, so it's a real pretty place. So you can just look up Andrews Research and Education Foundation and look for the Regional Anesthesia Preceptorship, or you can go to the ASA website where they have the calendar of CME events at the ASA website, and they'll give you a link to help register there. You can just online register, and we'd love to have people come by and see us. We've had people from all over the world literally come by, and we'd love to have people come. And by the way, speaking of that, if we have anybody in Europe, I will be at Ezra in 2 or 3 weeks. So if I see you, come up and say hi. I'd love to shake hands and meet the people that might have been watching this webinar. And like I said, we'll finish with a sunset from my house. And there's
beautiful
the bridge that I take to work, and the Andrews Institute sits right over there. 3 whole miles. That's 1 mile of it right there. And so
nice.
With that, we'll move on. Oops.
Awesome. Thank you, Dr. Hickman. So much great information. I'm just going to do a very quick live demo while we're waiting for more questions. So please use the Q&A function and ask all the questions. We'll do our best to get to them, but I'm just going to walk over. We have a model, so I'm just going to show you a supraclavicular, the area where we would do the block here. Good. So I'm just going to sit down beside you here, Bernie. So yeah, you can put your arm back. So as Dr. Hickman said, I'm just going to go kind of just lateral to the sternocleidomastoid and here, and then and the clavicle, and those are my landmarks. So we'll just place the scanner here, and I'm just going to decrease my depth a little bit just for a little bit of a better frame of reference. So I'm just going to come down, and we are seeing the subclavian artery, which is the black pulsatile vessel right here. And I'm just going to rotate the scanner a little bit so that the back of the scanner is just away from the clavicle a little bit, just as Dr. Hickman mentioned, so that we can see the nice shadow from the rib, which we're getting right here. Is that right, Dr. Hickman?
Yeah, you can see the clavicle right there. You see the pleural on each side, right and
down
left.
Here, and then over here.
Yeah, down there. Yeah, down there.
Okay.
Down there.
Okay.
And
then here's our bunch of grapes right here. Is that right?
Grapes all bunched up. Yeah, really tight on your patient there.
All right.
And are you aiming the probe kind of at an angle, or are you shooting straight down his body?
I'm kind of shooting straight in, like I'm kind of perpendicular
to
his
tell,
skin.
I think, from our camera angle. Okay. Yeah, there you go. So try rotating just a little bit more. I think we can get more rib. Wow. Yeah. There you go.
Oh, there we go. Okay. Gotcha.
Yeah. There you go.
Oh, wow. Okay. Well, that's great. So then there's our bunch of grapes right there.
Mm-hmm.
And then we would be coming in from this side here, which is going to be posterior lateral kind of
correct
angle, right?
Yep.
Excellent.
And try to come right down into that corner pocket. That's a tough one right there. That one's compact.
Yeah, it is. Yeah.
I might move to an infraclavicular on that one.
Would you?
Yeah.
All right. Well, in the essence of time, I'm just going to kind of leave it there, and we will just want to show just a little testimonial from Dr. Alan Hirahara, who's an orthopedic surgeon and uses ultrasound to do a lot of his pain injections. And he says that the new Clarius HD3 is almost like a traditional cart-based probe without the wire and without the cart. If you put it behind the iPhone, you literally can't see it. And what I was most blown away by was the new color Doppler feature. In addition to the actual quality of the image, you're getting it wirelessly. And it's on par with any corded device that I have ever used. So we'd like to give you all the opportunity to ask questions. So please feel free to click on the Q&A button, and you can enter any questions and over the next couple of seconds or a couple of minutes, and we'll do our best to get to your questions. And if we don't, we will certainly have somebody respond to you. So stay tuned, and I'm just going to hand it back to Janess.
Yes, thank you so much, Shelley, for the live scanning. It's always so exciting to see the new HD3 in action. And thank you, Dr. Hickman, for all your ultrasound strategies for effective regional blocks. It's so educational to have the opportunity to peer into the clinical environment to see actual patient cases. So we certainly appreciate you sharing your best practices with us today. Our live Q&A session will begin at the top of the hour. We will go over time to allow time to answer your questions, and we see we've got dozens here. Before we open up the floor to live questions, we'd like to ask a quick poll to help everyone continue their journey in bringing ultrasound guidance to their practice. So if you would like to get a quote and understand pricing in your region, we do offer Clarius again in dozens of countries internationally and in various currencies. So please do select quote or pricing if you'd like us to provide information on that. If you'd like to speak to one of our experts, we'd be happy to book a call with you. You can book a Clarius demo, a virtual demo where we set up a Zoom room and we can answer questions live and show live scanning. If you'd like to discuss features, we can set up a call for that as well. Or if you'd like to watch more tutorials with doctors like Dr. Hickman, please go ahead and select that option. While you are completing this poll, I'd like to take a minute to introduce you to our new Clarius HD3, the world's only third-generation line of portable ultrasound scanners, now 30% smaller and lighter. With an integrated battery, Clarius HD3 delivers best-in-class wireless ultrasound for regional anesthesiology with an easy-to-use app powered by artificial intelligence and connected to the cloud. Today, the new Clarius HD3 high-definition scanners are available throughout the USA, Canada, Europe, the United Kingdom, Hong Kong, Chile, and dozens of other countries. Our Clarius linear scanners are specifically designed to effectively guide regional blocks with superior MSK and needle imaging. They deliver several advantages for the nimble anesthesiologist. Clarius is unrivaled for near-field and high-resolution imaging in a handheld device. This best-in-class imaging is what you need for great tissue and needle visualization. As you saw today, you get clear view of nerves, vascular structures, clear anatomy, and your needle for safe ultrasound-guided injections. The secret lies in each scanner with 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in traditional systems, but at a fraction of the cost. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Clarius is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no more wires getting in the way or touching your sterile prep area. With no wires, Clarius is also so much faster to clean, disinfect, or fully encase in a sterile bag. Only Clarius delivers linear scanners with an ecosystem that includes free apps for your iOS and Android devices for unlimited users. Available with our new membership, Clarius Cloud is available to easily capture and manage unlimited exams from anywhere. Your membership includes Clarius classroom videos with experts like Dr. Hickman and onboarding with a Clarius clinician to build your ultrasound skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague or a second opinion. We'll now close off this poll in 3, 2, 1. Thank you. If you ask for more information, we will get back to you in the coming week. Now, there are 2 additional upcoming webinars that you may find interesting, so we'll share 2 quick additional polls so you can easily pre-register today. If you're joining us today from the United States, you're invited to join Dr. Alan Hirohara and Dr. Alberto Panera on June 28th for the live webinar, Optimizing Reimbursements for MSK Diagnostic Exams, Ultrasound-Guided Injections, and Rehabilitation. Doctors Hirohara and Panero will offer comprehensive guidance to billing and coding for both diagnostic and therapeutic MSK ultrasound to optimize reimbursements. Please complete this poll to pre-register, and we'll send you a confirmation email in the coming days. Now on to our next poll. I'm also pleased to say that we'll be welcoming back Dr. Hickman in August. You are all invited to join Dr. Hickman again for the August webinar, Expert Ultrasound-Guided Blocks for knee surgery, IPAC, genicular nerve, and adductor canal techniques. It's an opportunity to learn his expert ultrasound-guided techniques for providing the best postoperative pain relief for patients undergoing knee surgery. Again, please complete this poll to pre-register, and we will send you a confirmation email in the coming days. 3 more seconds, 2, 1. Now on to our live Q&A session. I'd like to welcome back Dr. Hickman and Shelley to answer your questions. Please use the questions icon in the menu bar to ask your questions of our great clinicians. Shelley, I'll invite you to moderate, please.
Thank you, Janess. We have a ton of questions, and I'm just kind of quickly looking through, and bear with us. Dr. Hickman's agreed to stay over a little bit. I realize that we're up at the top of the hour here, but several questions on sterile technique or aseptic technique, Dr. Hickman. What do you recommend, or what do you do in your practice?
So a lot of people will use a sterile condom and cover up their probe. We have never done that. We wipe our probes down really well after each use. We use a non-alcohol wipe because alcohol is not good for the surface of the probe. So we've been doing this for 15 years, 16 years. And really, that's worked well for us. I know it's a big question for a lot of people. And so that's all we do. We just clean the probe off really well between each patient.
All right. Thank you.
I see a lot of good questions on here.
Yeah, there's tons. Yeah. What are the risks of inadvertent pneumothorax with retroclavicular approach?
So again, you're really outside the thorax. And if you keep that probe lateral and you're not seeing ribs, if you've got the probe in the delta pectoral groove and you're shooting straight down with your probe and you see your needle, you make sure the needle lines up behind the clavicle and comes out right under your probe. You should be really way outside the thorax. And I haven't seen any documented cases yet of a pneumothorax with that approach. I'm sure it can be done. It certainly could be done. If you have the probe angled too medially and you're seeing ribs and you're going in that direction, it's possible. But it should be really, really safe if you've got the probe lined up and you're seeing your needle.
Okay, thank you. Is there any evidence that performing blocks on awake patients is safer than already anesthetized patients?
This was a big topic just recently on the ASA forums online, and so this goes back to an article that Jonathan Benimoff wrote in 2000. And what he did, he was asked to review 4 cases of interscalene block done under general anesthesia where there was actually an injection into the spinal cord. So the big controversy then was, you really shouldn't be doing interscalene blocks under general anesthesia. And before that, I had done lots and lots of interscalene blocks under general anesthesia. But after that was reported and his article came out, we decided it was not smart to do that. So we quit doing it. That was before ultrasound. Okay. And so it's funny to see this controversy still being asked now that we have ultrasound, because with ultrasound, I don't feel like it's that big of an issue. Now, we do most of our blocks preoperatively with an awake patient. I still prefer that, but certainly don't have any problem really doing any block under general anesthesia. If you're experienced, you have experience with ultrasound, and you can see your needle and you line it up with your ultrasound and you're safe, and you're not going to go into an area like the spinal cord and cause, horrific injury or a pneumo or something like that. I certainly think doing it under general anesthesia is fine. I think your question was there any literature say it's safer with an awake patient? I don't think there is. I think just everything goes back to Dr. Benimoff's article back in 2000, way before ultrasound. Yeah. Great. Can I answer a few of these real quick? I see.
Yes. Some. Help yourself.
So, how much epi do I recommend? If you're going to mix your own, I'd make it 1 to 400,000. The bottles, what I understand, the bottles with epi pre-mix. Of course, we can't find bupi with epi pre-mix anymore, but that's 1 to 200,000. And when I was a resident, we used to mix it 1 to 400,000. And apparently, the epi kind of, I don't know, it has some kind of effect on the bupivacaine in those pre-mixed bottles anyway. So I think it's better if you add the epi to it yourself. A really good question here is preservative-free dexamethasone. Do you use preservative-free dexamethasone? Definitely, strongly recommend that. When we first started doing that, we didn't realize that it needed to be preservative-free, and all of a sudden our hand surgeon says, "Hey, did y'all do something different this day?" And we said, why is that? And he said, well, these people are still having numbness like a week afterwards. And I'm like, okay. And then we looked at it and said, yeah, we got to get preservative-free dexamethasone. So good question. And yes, highly recommend. I don't add dexmedetomidine. That's just not something we have experience with here. We don't have it in our ASC. So that's not one that we do. Can't really answer questions about that. Good question. Where'd we go? Duration of a block. Have you used lidocaine and bupivacaine? I think one of the studies, we definitely have studies that show the onset of the block is faster with ultrasound. You get a longer duration with ultrasound because we're getting more local around the nerves. I know years ago when I was a resident, we used to mix lidocaine and bupivacaine to try to get a faster onset and a longer duration. But think about it, when you're adding these two things together, you're also diluting them. And so I think you will lose a little bit of your duration. Haven't done that in a long, long time because we just use bupivacaine in our blocks because we get it set up fast enough to be able to use. Now, if you're going in the OR and you're having to do your blocks in the OR and the surgeon's going to cut right away, yeah, you probably need to add some lidocaine or just use lidocaine because the bupivacaine is not going to set up fast enough for you in that situation. What else do you see, Shelley?
There was a good one that said, do you enter into the interfascicular space and inject local anesthetic there? Does it make the onset faster?
That's a good question. I think you're talking about supraclavicular blocks there. So really what I don't really try to do that. I really try to go between the cords. Between the trunks. I'm sorry, I apologize. So between the trunks, I'll do the corner pocket. Then I definitely go up and get between the upper trunk and middle trunk, and then try to get between the middle and lower trunks. But when I do that, sometimes I do get in that interfascicular space. I usually back off and don't put a whole lot in there. But I just feel a little more uncomfortable with that. Certainly there's studies, study from 15 years ago that said that was safe to do. And they actually called it an intraneural injection in the article. Although I never believed that was intrafascicular. I thought it was, intraneural. I felt like I agree with you. It's intrafascicular.
Right. Okay. I have kind of an ultrasound imaging related question, and I'm not sure if you know the answer to this, but why do the divisions in the brachial plexus appear hypoechoic when we compare them to peripheral nerve blocks like the sciatic nerve?
That's an absolutely great question, and I don't think anybody knows the answer. I heard a lecture one time years ago. I can't remember who it was. I think it was Dr. Bozart. And he tried to do an explanation. I'm listening to the lecture and I'm thinking about it. I'm like, okay, I kind of agree with that. Then as I was flying home from that meeting, I was like, well, that makes no sense at all. So I don't know the answer to that. And it's always a good question. It's question's been around since we started doing ultrasound guided blocks for sure.
Yeah. And I always kind of attributed it to the surrounding structures to a large degree, but that doesn't work 100% of the time either. So I'll have to try to find the answer to that.
Here's a good question. Incidence of hitting the dorsal scapular nerve while doing a limb in-plane long axis approach. And what he's talking about, I'm pretty sure, is an interscalene block because I cut through the middle scalene muscle, and the dorsal scapular nerve is right in the middle of the middle scalene muscle. And I see it maybe 50% of the time. And this is one of the main reasons I use a nerve stimulator, is I don't see it all the time, and that helps me find it. Actually, now I don't hit it very often because I see it or I get the twitch and stop and back up and go around it. So good question. And that's why I recommend the old nerve stimulator for this one. And also the long thoracic nerve, you can get that in, and it's really superficial sometimes when you first go in real posteriorly like I do, you can get the long thoracic nerve. So stimulating that, and you get you don't get a good deltoid twitch. It's more posterior. It's the rhomboids that you're going to get a twitch with that.
Right.
I guess we got off of our blocks, but
Well, I want to be respectful of everyone's time here, so I think we'll stop there. We will get back to all of the questions. We will answer them in an email. Dr. Hickman, thank you so much. So much great information there. And Janesse, I can hand it back to you. Do you have any final words?
Yes, I do. Yes, I do. Thank you so much for joining us. I know some of you stayed up quite late for this and others woke up quite early in the morning. So we appreciate you and all of your fabulous questions. There are dozens of questions that we didn't get to. And again, we will follow up with you by email in the coming week. You will all receive a copy of the slides and webinar recording as well. I'd like to thank Dr. Hickman for all of his insights, and a big thank you to all of you for joining us. We hope to see you again later this month and in August for our upcoming webinars. In the meantime, have a wonderful rest of your day and keep scanning.
Thank you, Janesse.
Thanks, Dr.
Thanks,
Hickman.
everyone.